I'm Dr. Rob Jones. This is my awesome wife, Shannon. We help you filter through all the complicated, huge amounts of information that you're influxed with every single day. As a clinician with 25 years of clinical experience seeing pain-related and sports-related patients, I'm going to help you get better from the outside in.
And as a dietitian that has 30 years of clinical experience, I'm going to help you get better, not older, from the inside out.
So basically today we're going to jump right into it and talk about chronic pain. Chronic pain is something that you've technically been dealing with for greater than 6, 8, 12 weeks. But honestly, most of the chronic pain cases that I see clinically are from people that have been dealing with a bum shoulder, a bad elbow, a bad knee, or a bad back for literally years. Now, the current model in medicine, if you ask me personally, and you could really talk to a lot of clinicians who do what I do from the musculoskeletal side, the orthopedic model really isn't that efficient, because what it does is it takes people who are in pain from a soft tissue injury like a tendon or a strain in a ligament or a joint, and basically puts them into this model of let's control the pain, whether it be with cortisone injections or medications like anti-inflammatories or muscle relaxants or obviously surgery. Now, to me, that's an inefficient model because you're treating the symptom at that point. I'm a cause guy. I look at foundation. If your knee hurts, I'm not just going to look at the area that you're pointing to and saying it hurts right here. I'm going to look upstream and downstream. I'm going to look at the ankle. I'm going to look at the hip. And of course, I'm going to look at the knee. But generally, because joints play together and they function together, if you've got pain here, sometimes it can be caused from up here. So going to, and again, I'm not trying to knock anybody, but if you go to a doctor and you say, my knee hurts, and they take an x-ray and they say, you got arthritis, but they didn't put their hands on you, they didn't test your knee, they didn't test your hip, ankle, or back, or muscle function, you're never going to figure out the cause. So that's my role, and that's how I look at things from a foundational standpoint from chronic pain. How do you address it?
Well, I mean, I think there's a lot of different ways we can go here. I think, you could very easily Google anti-inflammatory diet or a Mediterranean diet, which is known to help decrease the inflammation, which the inflammation is what is causing the pain. But I honestly like to take a step back from that and start to think of removing immediately the things that are actually causing the inflammation. Yeah. Instead of just trying to start to take, whether it be supplements or whatever, to address the inflammation. Mm-hmm. So I will get to that, but how about you finish up the inside, your part?
Okay, so if you come to my office for chronic pain, I'm going to assess a couple different things. Where it came from. Number one, an acute injury that you never dealt with. You sprained your knee doing whatever, stepping off a curb, getting out of your car. You lost range of motion. It hurts. You stopped moving. You never increased range of motion. You never got it back. Now you're changing the way you're walking. Your gait is off. You got pain. It's number one. Number two is a cumulative trauma disorder, meaning you've been doing something repetitively the wrong way over and over and over again, like a lower back issue where you've been sitting at your chair slumped, or you're a gardener and you've been bending over the wrong way. Now you've created some sort of disc issue in your lower back. There was never an incident, but it built up over time, and now all of a sudden it hurts to do X, Y, Z. You stop moving the right way, you change your mechanics, now you're in chronic pain. Chronic pain, generally, you can still function, it just hurts. A lot of people, they expect just to take medication or go to a physical therapist or see somebody like me and get out of pain in 6 weeks, because a lot of people will arbitrarily just throw out that number. 6 weeks, you'll be good to go. But a lot of times the data is fuzzy on that. It's the type of exercises you're doing, the foundation of fitness you had before, and how good your therapist is at addressing the problems. So let's say you come into me with a knee problem. Dr. Rob, I got chronic knee pain. It hurts to walk up and down stairs. It hurts right here. Okay, well, I'm going to assess where the pain is, but I'm also going to look at how the hip moves, how the ankle moves. And a lot of times, if you don't have proper range of motion out of the ankle, proper range of motion out of the hip, because those are two main moving points, the knee will actually have to pick up excessive range. So what I'll do is, if there's a hip restriction, I'll actually move that hip. Once I move that hip, and that functions better. I'll look at the ankle. If the ankle's okay, we don't need to address it. Now we look at the knee and see what's going on with the knee. If you've been moving improperly and compensating around that knee, we may have to stretch the quads. We're going to strengthen the glute almost 100% of the time, but you could have a rotation issue.
Can I insert something
Yeah.
here? What about the shoes that they're wearing? Because I feel like a lot of people discount a change in shoe or just even the platform that they're stepping on. How does that relate to what you're talking about?
Yeah, 100%. It's interesting. We've gone in the last few years into this model of we've got to wear these big, huge cushion shoes like Hoka's, right? Everybody, if you're a serious runner and you're running miles and miles and miles, then yeah, get some Hoka's, because if you're on concrete running the streets or whatever, you need some cushion. But if you're walking around and going from your car to the grocery store, your car to your office, don't wear Hoka's, because you're losing feedback into the ground. I actually am sponsored by Peluva, but I'm a huge fan of theirs simply because our feet are like our hands. We need to get our toe box in our shoes opened up and wider so the toes can actually spread like this. The vast majority of foot problems are caused by the feet being crammed in like this. Like women who have worn high heels forever and they've got this tiny little pointed toe box, you wonder why they end up with bunions, because that big toe is pointing over that way. Well, when you don't have your foot spread out and the foot can't spring like it normally does, that translates up the chain.
Doesn't it just throw everything off?
Throws everything off. But that's why I said, like, if somebody comes in and their foot and ankle are good, I'll move upstream. But yeah, if somebody has a knee problem and their hip is really good, then yeah, I'll go down to the foot, assess the foot. Maybe we need to work on the joints of the foot, get the ankle more flexible, work on foot stability, how they're contacting the ground, then come up to the symptom.
I just think a lot of times people discount evaluating their shoes. It's something that they have on their feet every single day. So talk about repetitive.
Yeah, 100%. Absolutely. Yeah, we have a situation where, I don't want to say 100%, but pretty darn close to 80 to 90% of foot problems, chronic micro-trauma-based or accumulative stress-based disorders of the foot, like plantar fasciitis, metatarsalgia, any type of foot pain that people are going to podiatrists for that don't need surgery, it's a shoe-related issue. Get your dogs out of the doghouse, meaning
God, the girls are going to.
Yeah, my kids are going to hate that expression, but let the cows out of the barn. Okay, you got to get your toes out. We've stopped walking on the beach. We've stopped walking in the grass. The foot shouldn't be trapped. It should be spread and it should be bouncy. Every time you step, you should distribute forces in a spring-like effect. There's muscles on the bottom of the foot that are about yay thick, and if they are not strengthened like any other muscle in the body, they're going to stiffen and they're going to get weak. So now you've got this weak foot, and people go, oh, I've got a flat foot. And then they'll go to their doctor or they'll buy them online and they'll get these high arches. Well, guess what? The high arch is going to make them feel better temporarily, but as soon as they take that arch support out, again, that arch support is giving them external support. They're not doing it themselves. So you need to find a minimalist shoe that fits your lifestyle. There's all sorts of brands, but for exercise, I wear and recommend Peluva for exercise. Walking around in my clinic, I do Peluva and I do Noble because they have a wide toe base. But yeah, to answer your question, if the foot is addressed and the hip is addressed, then we'll go up to the knee, basically.
And don't you think everybody should go walk on the beach?
Well, if you live close to a beach, heck yeah. If you don't live close to a beach, I used to tell people back in Kansas, where I practiced for 21 years, that had plantar fasciitis. There's no beaches in Kansas, folks, unfortunately. But I used to have them do certain exercises for their feet, and I would say, take your shoes off, go walk around in your grass. Okay, just go in your backyard, let your toes spread out. The problem is everybody's always in shoes, and we weaken. I actually have people balance that have foot pain. Like I make them get on an Airex pad, spread their toes out so it's a little insecure or unbalanced, and they basically, I make them grip the ground so they can actually strengthen the bottom of the feet. But yeah, huge play for the knee as far as the foot.
I get in trouble when I go for pedicures because my feet are so dry and like just my heels and stuff, because I'm barefoot all the time.
You get in trouble by who?
The people doing my pedicure.
Okay, well, they don't know what they're talking about, so go and get your toes pretty and then run away. But yeah, okay, so that's an example for the knee. Now, when it comes to the shoulder, if you've got a chronic problem with your shoulder, it can be something to do with the middle back. I actually saw a college pitcher yesterday in clinic, and basically he was talking about how he had shoulder pain. He was a lefty. He had shoulder pain when he was back here, and basically we went through all these shoulder tests. Nothing was positive. Fruit fly, I got him. So when I tested his shoulder, we went through all these ranges of motion, all these strength tests. He had zero problems with his shoulder. It was beautiful. He had good range of motion. Now, if I had just said, you got tendonitis in your shoulder, let's give you a cortisone shot, even though I'm not licensed to do it. But that's what happens at a lot of ortho clinics, because they'll take a picture or they'll take an MRI and they'll see a little bit of inflammation in the tendon, and they'll go, that's your problem right there. And they'll give him a little shot, and they'll actually get a little bit better temporarily. But that's how you set up the chronicity of the problem, because he continues to pitch and they don't get to the source of the problem. I can't tell you how many times people go to acute care clinics, get x-rays and MRIs, go to ortho offices, go to their doctor's offices. Nobody does any testing anymore. They don't put their hands on them and feel them because it takes too long to do it. When I go through my steps clinically, I look at the source, I look upstream, downstream. I checked his elbow, everything was good there. Checked his hand, everything was good there. So then I had him do some thoracic mobility tests, and I found right away that he didn't move very well through his thoracic spine this way. So if you think about a pitcher, and I'm going to do it right-handed because I'm right-handed, he was a lefty. If you're a pitcher, you have to rotate your thoracic spine and then be able to get your arm back in this position to deliver the ball. Well, he was getting his arm back as far as it could go, and he kept saying to me, I feel like I can't get my arm back as far as I can go. And that was because he wasn't turning here. And his shoulder was bugging him because he wasn't turning here, so he was having to excessively rotate back.
Kind of hyperextend?
Well, not hyperextend, but he was having to over-rotate back this way. So that would have set him up for some sort of damage later because he couldn't rotate through his thoracic spine. So what we did was I showed him two of my favorite thoracic spine range of motion movements, and then my clinic's big enough that we can have him pitch a little bit. Pain was gone within 20 minutes. It was easy. But again, had he gone down that rabbit hole, and again, not trying to knock the medical model, there's some really good ones out there, but had he gone down the medical rabbit hole, it would have been primary care. Oh, go see an ortho. Go see an ortho. Oh, x-ray. Oh, maybe we see a little calcification. Better get an MRI. Oh, inflammation. Yeah, because he probably did have a little inflammation in the tendon because he was over-rotating. But again, address the source of the problem, you're good. Don't address the foundational source of the problem, we've got chronic pain. And that's what most people are living with that have chronic pain. They've never discovered how to get to the foundation.
I don't know. I'm just thinking of this, and I think it's interesting. We recently had a friend, when you're speaking of when people get in issues or pain or whatever, and they immediately go to the emergency room, where she could not get up.
Yeah.
And they FaceTimed us, and you guided her through that. Do you want to talk about that?
Her husband actually texted me and said, I need you to talk to me right away. She can't get up from this chair. So I FaceTimed and I said, what's going on?
And can I add, she has historically had hip issues.
Yeah, she's had some hip issues because she had an auto wreck years ago, but she's generally functional. She can walk and exercise and even jog a little bit. But so I got on the FaceTime, she's sitting, and I said, okay, so what's going on? She said, I cannot get up from the chair, and I cannot lift my hip. Right away, she was talking about the sharp stabbing pain in the front of her hip. And she said, I've been trying to stretch my hip flexors, but that's not working. Well, feeling like you have a tight hip flexor and trying to stretch that is basically contraindicated, because really what was going on, and this is, I'm not any smarter than the next person, but it's easy to recognize if you know the symptoms. She had an anterior translation of her femur. So the ball of the socket, the femur's a ball and socket, the ball had slid forward a couple millimeters. And even though it's just a little bit, it pulls on the labrum, which is the connective tissue of the hip, and it's really, really painful. So all we did was do some simple glute activation exercises for that left side. After about 10 minutes of doing them, the glute tensions and it pulls the femoral head back in so it can rotate properly. And she got up and she had zero issues. Now again,
Had she gone to the ER,
Her
it
hus-
would have been muscle relaxers, blah, you know.
Anti-inflammatories, she would still be hurt because you can't ever get into an ortho right away. It would have been limp around for many, many days, maybe get into an ortho within a week. Oh, you x-ray it. And because she's had previous trauma, she showed me her x-rays before. And she does have some degenerative arthritis in her hips. So an ortho would have gone, oh, hip replacement. Because if you look at her hip, she looks like she needs a hip replacement. But this is where the scans, this is what I tell patients all the time. The scans don't give the true clinical picture, okay? If somebody comes into me and says, oh, I have arthritis in my back, and I assess the area and it moves right, I don't care if they have arthritis. We all have arthritis when you get to our age over 50. It's how the area moves. So long and short of it, even if you have some arthritis or some breakdown, if you get to the right sources and you know the things to do, you can get out of these things, right?
Where would our GBNO listeners find answers to these chronic pain issues?
Well, it's interesting you say that. This is why we created all the programs at heydrrob.com. I have a hip protocol that describes the symptoms. If you go through the protocols, you will get yourself out of pain. It takes a little effort, but the 4 or 5 exercises that you can do will get you out of pain.
Now, I think most people would think that they would need to see you in person to get this help.
No, not necessarily, because basically on the videos you'll see, I'll explain, I'll say you have this pain right here or you have this pain here, do this exercise if you have this. It's no different than when medical doctors prescribe medication for a symptom, right? You go into the doctor and you say, oh, I have pain here to touch and my head is really full and I have like water in my ears, I feel plugged. Oh, you have a sinus infection. You need a decongestant, here's a medication, and you need an antibiotic, okay? That's an algorithm that is followed, okay? I have kind of set out, it's not really a true algorithm, but I will say in the videos, if you have pain here when you do this, do these exercises. When you have pain here, when you do that, do those exercises. So it's very, very easy to follow. And that's why I did it. So we can take all the guesswork out of it.
Well, and so then now I'm going to talk a little bit about something that we have coming, which is super excited, which is our GBNO community all in one place. Mm-hmm. And they will be able to, instead of going to the website and having to look to find this, everything is going to be organized in one community where all of our podcasts will be there. We're doing some fun new things for all of our members who choose to be a part of the GBNO community, where we do weekly input, like for instance, table talks, which we did last night, which is just Rob and I sitting here at dinner and talking about our day and talking about interesting patient care or studies that we just read that has really good data, etc. We're also going to do a question and answer session where we just answer people's questions, and that'll be in one section of the community. Also, you and I, while we're out and about, let's say we come across some great products in the grocery store, or you come across something that you think would be great for rehab, we're going to shoot a quick video to let our community know about some great things, and that will be there too. So even more of a resource. It's not just about pain, but it's about functional nutrition. It's about great new products that we see. It's all encompassing. So it's almost like trying to be a search engine, but we're the search engine. And there will be a section for nutrition where I'm already going to have an ebook for them available and all these resources just for being a member. And then you too are going to have a lot of these protocols that are accessible free of charge for our community. So that's coming soon. It's called the GBNO community.
Stay tuned. Okay, so we're going to take a quick break here on the podcast to answer some questions. So, Dr. Rob, how can strength training help combat age-related muscle loss and improve overall health? Age-related muscle loss is a big topic right now. And if you get on social media, you'll see, up to, sometimes 8% per decade over the age of 30. Well, if you look at me, I'm 52, and I have just as much muscle as I did in my 30s, and I'm not on any TRT or anything like that. The most important thing to do is get on a good balanced program, and again, hate to kind of pimp my own stuff here, but the GBNO program is designed for age-related muscle loss over 40. You have to have a couple of things incorporated. Number one, you have to have frequency. You've got to go 3-4 times a week to the gym. Number two, when you get to the gym, you can't just get on a machine and go, okay, I'm working my muscles, I'm good to go. You have to have some intensity, okay? And you always want to keep your rep range a little bit north of 12 reps. I try to keep mine 12 to 15. And in those last 3 to 4 reps, it has to be hard to the point where your form is not breaking down, but when you're at 14, you're going, 15, and you can't wait to be done. You have to have that stimulus of those hard reps. Now, number two is it's going to improve your overall health because you basically are going to have more muscle mass. More muscle mass is like having a bigger engine. If you have a bigger engine, you're going to burn more calories at rest. You're going to have more heat in the system, creating more caloric burn. So if you miss a couple of days of working out or you have a cheat meal, it's not going to impact your health that much because your engine is still going to be revving. So that's one of the quickest things you can do and one of the most important things you can do for age-related muscle loss. Now, number two, the second question was, what are the best ways to prevent joint pain and injuries during workouts for those over 40? The first 2 weeks of the GBNO program are teaching you how to move right. If you go into the gym and you're going to do biceps and you're just doing this and you're doing a shortened range of motion, you're going to limit what that joint can do. So the most important thing is not to have so much weight that you can't do a full range of motion. Moderate amount of weight, full range of motion while you're exercising in those 12 to 15 really hard reps. And then when you get done that day, it doesn't matter if it's right after the gym, but I try to do it before I go to bed. Stretch what you worked that day in the gym. So if you do chest and triceps, or if you do hamstrings and quads, stretch those muscles before you go to bed so they don't tighten up so you cannot lose your range of motion.
Hey, Dr. Rob, how would they know what stretches for each?
Well, we've got over 1,000 videos on all the platforms, so there's tons of information. If you don't know how to stretch your quad, you can buy the flexibility program and the GBNO program or at Hey Dr. Rob, or just go on Instagram or YouTube. I've got tons of stretch protocols, so it's going to be very easy to find.
Okay, my turn?
Your turn.
Okay, Shannon, how does stress affect weight loss and metabolic health in people over 40, and what can be done to mitigate its effects? Well, so stress, honestly, is one of my first parameters that I have everybody evaluate before we even start jumping in, because it can actually trump everything I am trying to do. I want you to imagine we're still farmers and you're out in a field and you're working the field and you come across a snake. What's the first thing you do? You scream and your cortisol shoots up, and that gives you the energy to get the heck out of there, okay? Well, what do you do to get the heck out of there? You run. What reverses cortisol? Exercise. So that is how that system was meant to be. Unfortunately, in this day and age, we are sitting a lot of the time that we are still creating these cortisol spikes for whatever reason. We're getting stressed out, and then we're not moving, meaning it just chronically stays high. Well, I want you to think about back when you were in that fight or flight situation. That is meant to be in a acute situation, get in and out and done. You're not supposed to have chronically high cortisol levels because your body is in that constant fight or flight state, and you're not doing everything else efficiently if you're in that state. So mitigating stress is one of the primary things we work on before we even jump into making other changes. I would say over 40, you're in the thick of it. You know, life is throwing us all kinds of curveballs during those years. And so you do have to be mindful about incorporating ways that reverses that cortisol spike. Clearly, the number one way I would recommend, because it also is going to alleviate a lot of other issues, is exercise. and creating muscle mass and being active, getting those 10,000 steps a day like we've talked about. But also there are other things that we can do that can help. Meditation is a big one. There are a lot of data behind meditation. Acupuncture can help. There's a lot of good data behind acupuncture. Just journaling. There's all kinds of things that we can do to just take a minute and try to work on reversing our stress, because it will absolutely, it is one of those situations that your body just says, stop everything else. She is in, or he is in, a very, what would you say, dangerous situation. You're not going to be digesting properly. You're not, your blood sugar shoots up so that you have, all of a sudden you're taking sugar out of muscles for energy so that you can run and get away from whatever you're in trouble. The problem is we're not running to get away from the trouble. So it's a system that's not working for us as we've evolved. So make sure you incorporate something in your day to reverse that cortisol, because you will have weight gain if you don't do that. It's just part of what happens. Okay, question number 2. Can intermittent fasting be beneficial for weight loss and metabolic health in older adults, or are there better approaches? There is a lot of really good data on intermittent fasting. And I would say this, if you feel good by fasting, then do it. If you don't, then don't. I think everybody should make a practice of fasting for no less than 12 hours a day. So that means if you stop eating at 7 p.m., you shouldn't start eating until 7 a.m. the next day. I think that's a minimum. The next thing is you start to think of, okay, well, if we're wanting to improve other metabolic factors, you can definitely increase that number. I would stop at around 14 hours for a woman, and then you can go up to 16 for males. Most of the data we have on intermittent fasting is done on males. So that's part of the problem. But it can cause other hormonal issues for women if we go beyond the 14-hour mark. So there are good things that can come from intermittent fasting. But if you are like struggling through it, like if you're waking up super hungry and that's a meal that you typically enjoy and it's a healthy meal, as long as you've fasted for 12 hours, I think there are other ways that you could go about losing weight than forcing yourself to intermittent fast. I think it's one of those things that can be beneficial, but it doesn't have to be. Typically, what's happening, the reason why it's working for most people is you're pretty much eliminating one whole meal. You end up eating probably 2 full meals and having a snack, perhaps. The thing I don't believe in fasting is when people are binge eating and they're binge eating crap in their eating window. So you got to still make sure you're nourishing, that you're getting all the nutrition that you need. So just shortening your window of eating is not the answer to everything. You have to be mindful about what you're doing within the window. All right, that's it.
Good Q&A. Back to the podcast.
Cool.
Yeah.
Okay, let me mention 2 more things, and then I'm going to push this over to you.
Okay.
So biomechanics is a really tricky word, right? It's like, ooh, what does that mean? It sounds like physics or something. Well, biomechanics just means how the body moves. If you can restore biomechanics, which our story about our friend with the hip, we just restored normal biomechanics in her hip. If we can restore biomechanics in most cases, even with a bad joint, and the muscles work better, you can get most cases out of pain and better function. Now, there's something called arthrogenic inhibition that I want people to understand. Arthrogenic inhibition, anytime you hear the term arth, that means joint, okay? Genic means to generate, right? Like the book of Genesis. Inhibition means to shut something off. So think of a light switch shutting off. So when you have arthrogenic inhibition, think about the knee again, okay? If your knee isn't functioning right because of something below and above and it hurts, your brain is getting feedback from what's called proprioceptors, okay? It's like when you touch a hot surface, you pull your hand away really quickly because the proprioceptors in the skin recognize that you may burn yourself, and your brain says, hey, dummy, get your hand off that. You don't have to think about it. It's a reflexive activity. It's unconscious. If you have pain somewhere, your brain is going to interpret that as a problem. It thinks you're going to do a lot of damage to the area, so it shuts the lights out to the muscles around said area, okay? So if you have a knee problem that's chronic, it's been going on for months and months, years and years, it hurts to do whatever, step down from a curb or out of your car, stand up from a couch or toilet, your brain is going to go pain, 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 shut down the quads, shut down the hamstrings, shut down the other stabilizers in the knee. Now you're going to try to go move out of that knee. Now you can't because you don't have any power, okay? So even if you go into the doctor and get a cortisone injection into that tight tendon or that painful joint, and you don't address the arthrogenic inhibition, you are now a ticking time bomb because you've got an anti-inflammatory going. That knee doesn't hurt. Okay, so now I can move a little bit better, but the muscles aren't working right. So now you're at a little bit more risk for further strain. And I'm not trying to scare people, but you're creating an environment where you're not creating better biomechanics.
Well, and I think it's important to stop and remember, okay, so we're talking about chronic pain. Mm-hmm. The inflammatory response is there for a reason, to create the pain so that we know that something's wrong. Mm-hmm. It doesn't do any good, as we have said, with numerous situations to mask the pain with symptom relief. We need to figure out where it's coming from.
Also, inflammation is what creates healing. So the guy from Harvard who created the term RICE, rest, ice, compression, elevation, I think it was back in the 80s or 90s, back in 2014, after studying it further, he doesn't want people to ice anymore. I still like to ice if something hurts because I feel like it's a good pain mitigator. Yeah, so we need inflammation because inflammation doesn't just warn us, with pain. It's actually how we heal, right? So the guy from Harvard, can't remember what kind of scientist he was, but he came up with the acronym RICE, rest, ice, compression, elevation, back in the 80s and 90s. That's what we learned in undergrad when I was doing my athletic training stuff. Wrap that joint up, ice it down. Well, he changed that in 2014 to, originally it was mice, mild movement, ice, compression, elevation. Now he doesn't want any elevation, maybe a little bit for some swelling, but no ice at all because it hinders the inflammatory process and can actually increase the inflammatory process too much. But they want mild movement, okay? Because the movement is what stretches the tissue. It's what takes the joint through a range of motion, and it's what flushes everything out. It bails out the boat, basically. So you need some level of inflammation to get healing. That's another reason people who are on chronic doses of anti-inflammatories like Advil or Aleve, yeah, it helps you with the pain, but you're basically diminishing your body's response to inflammation, which it needs for healing.
Plus putting your gut at big risk.
Here's another thing. To build muscle, you have to have a small inflammatory response in the muscle after you've done therapy, strength training, or whatever. The inflammation stimulates satellite cells in the muscle cells to actually increase the biochemical functions that increase hypertrophy, which is muscle building. If you shut down that little bit of inflammation with Advil or whatever, you have no satellite cell activity. So now you've got no positive benefits. So if you're taking Advil or Aleve and going to the gym and working out, or Advil or Aleve and going to therapy, you're mitigating the positive responses from that. So you've got to have controlled inflammation, basically. And then one last thing, and I'm going to hand it over to you.
Dr. Rob, you have a lot to say.
This is an important topic. She always says I talk too much. Now, with regard to inflammation and tissue damage meaning your cartilage is a little bit broken down from your arthritis, or you've got a tendon that's really weak. I don't want you to think of it as arthritis. I don't want you to think of it as tendon weakness. I want you to think of it as a lack of collagen, okay? We know now that it's a slow process, but you can increase collagen activity by taking exogenous collagen or collagen supplementation. Shameless plug for Transparent Labs, but every morning in my tea, I do a scoop of collagen hydrolysate through transparentlabs.com. You can use code Dr. Rob, you get 10% off. I don't know what collagen you use, but you put it in your coffee every morning, right?
Yeah, I have to use a special kind just because of my allergies.
Yeah, you're okay. So basically, we should be taking collagen. You know, back 80, 100 years ago, when we were killing the chicken out in the backyard and we were eating the drumstick, nothing went to waste because you couldn't just go to the grocery store, right? Or when we were hunter-gatherers, we were literally eating the bone, gnawing on the bone, eating the cartilage on the bone, the gristle, which totally disgusts me. But we don't get enough of that in our diet. We're not eating the skin anymore because we were told the skin was high in fat. Remember that? Back in the 90s, don't eat the skin, it's high in fat. Well, it may be high in fat, but it's also high in collagen. We need that. So if it grosses you out like me, and you don't want to sit there and gnaw on that cartilage, kind of turns my stomach to even think about, get a collagen supplement. That's going to help with the tissue repair. So in a little synopsis here so I can hand it off to Shannon from the inside out portion. Chronic pain doesn't have to be chronic. If you know the right people to see, the right things to do, and then how to control the inflammation the right way and what to do with your diet. It is not hard. We don't have to be in chronic pain. It's not part of getting older. That is for sure.
That is for sure. And I will say, chronic pain is debilitating.
Yeah, we've both had it.
Yeah, on weeks that I am having issues with it, it really does manipulate your quality of life.
100%.
Yeah, for sure. So it's something, instead of just putting Band-Aids on it, we actually need to work on fixing it. Mm-hmm. I said earlier that I really like to kind of take a step back and look at this as, well, what can we actually make sure we don't consume that creates inflammation systemically?
So what would you say the number one thing to take away?
I would say three top ones for me, which is sugar. Mm-hmm. Okay, and so that includes any refined processed carbohydrates as well in that, okay?
Give me an example.
Well, okay, so let's just talk about table sugar in general. Table sugar is, clearly it's a natural product. However, it is not something that we need to nourish or maintain or improve our health. Mm-hmm. It is a definite inflammatory ingredient. Mm-hmm. So that would be one. But then it takes on new faces in high fructose corn syrup and other refined processed carbs that are genetically modified or made in a test tube, et cetera, et cetera. Processing of those can be damaging.
So Eggo waffles, cereals. So
ultra-processed foods, everybody's kind of hearing a lot about this. Mm-hmm. And honestly, even as much as you and I try to eat very simply as far as few ingredients as possible, mm-hmm. even the protein bar that I eat is considered processed because it has more than one ingredient. Mm-hmm. That being said, you have to be wary of a label that this is this long, right? Mm-hmm. That to me is processing, mm-hmm. where you can't look at the ingredients and simply tell what you're putting in your body. That mm-hmm. to me is processed.
So if the ingredients list is long, but it's long with things like whey protein, organic, nuts, organic.
That's what I said, is if you can recognize and identify what it is that you are putting in your body, that's fine. Yeah. That is also considered processed, but I'm talking genetically modified, created ingredients that our bodies were not ever meant to take in.
The super long scientific looking words, maltodextrins and all that. If you see that on your label, you shouldn't be eating it.
And the problem is your body is responding to that because it doesn't know what to do. So I would say sugar, anything refined, ultra processed is one. So if you remove and do your best to remove those, you mm-hmm. will be removing some of the biggest culprits. Yeah. But then I would add in trans fats and saturated fats too, because they tend to be inflammatory.
Give me an example of some of those fats.
So saturated fats are solid at room temperature, mm-hmm. And that would be, you know, your beef tallow, your lard. Think of, I mean, if you want to talk about the worst ultra processed fat ever is Crisco.
Because that's all vegetable oil based, right?
Exactly. But then we get into trans fats, which is it's a processing where they're trying to take a saturated fat, not trying, but they take a saturated fat, they remove some hydrogen bonds, and it turns it into a less saturated fat. Unfortunately, that process of hydrogenation is just as damaging. So
I thought they added hydrogen ions to it.
no, you're removing.
Gotcha.
Because the bonds are saturated.
That's why I don't argue with her. So you're going to get some you're going to get some argument from the carnivore community about, because there's a lot of anecdotal data that people who have chronic inflammation went to more carnivore diet, more beefs, fatty beefs, saturated fat, and they got rid of lupus and rheumatoid arthritis and the chronic pain and that sort of thing.
Okay, so let's talk about that.
Yeah.
That is not always the case for everybody.
Yeah.
Right?
Yeah.
So if
That smile was because we've got a really good podcast coming up about yours truly.
Yeah. So if that's great, if you want to be a carnivore and you want to take in all of that saturated fat, but you better be very proficient at getting rid of shipping those fatty acids out. Okay. And if genetically you are not,
Hint, hint.
then that's a problem.
Yeah.
Okay. So we can't, all of these diets, we can't just say, do carnivore. It's great. It's anti-inflammatory. It's this, it's this. It's not for everybody. Okay. So that's why I said some saturated fats. And I would start with more of the processed saturated fats versus those that we get with one ingredient, which is the beef tallow. And honestly, if you're doing organic and grass-fed, it's always the processing. Always. It is never really the poor little food. It's always what they do to it that is the problem that typically causes inflammation.
So that leads into the biggest, two buzzwords of the last year probably are seed oils.
And yes, seed oils, because of their lower degree of monounsaturated fats, can be more inflammatory because they are polyunsaturated. The problem with the seed oils, again, is the processing. What they do to our microbiome, what all of that processing does to the way we then metabolically process it. If you take sunflower oil, let's say, and it's high oleic sunflower oil, that's actually bumping up the monounsaturates in it, and it actually is a good thing. So it's not across the board, but I think you have to understand how it was made and then what your body does with that, the types, and we can get into all of that. I do get into that in my protocol on fats. Okay. So that so far is processed foods, sugars, some saturated fats, all trans fats. And those now you will find trans fats on labels. That is part of labeling laws now. Okay. Then, the elephant in the room is definitely alcohol. We do not have a way to really detoxify alcohol. So your body has to do all these crazy things to try to get rid of it. And it is an inflammatory process. Excessive. I would say. One, if you have cirrhosis of the liver, I wouldn't drink it at all. But, it's one of those things that definitely needs to be in moderation. Okay?
Just clinically, I'll actually take patients who have chronic pain and I'll say, while we're going through this, even if you don't want to do the exercises at home, at least clean up your diet. Don't drink any alcohol and watch what happens. And I will tell you, you know how I love birthday cake. So anytime it's my birthday.
Any cake of any kind.
Any cake. Cupcakes, it's my weakness, okay? But it's crazy, and just to quote Joe Rogan here, for a little bit of mouth pleasure, it's crazy how shitty I feel the next day. Like, if one of the kids has a birthday and I eat 2 huge pieces of cake, my knees will hurt worse the next day, my shoulder, anywhere I've had a ding in the past, my back, my left knee, my left shoulder, it always aches worse the next day.
And here's the problem is I honestly don't think people understand how bad they feel.
100%.
I do not think anyone, like one of the things I love to do is when my patients will give me 30 days and they will do what I ask them to do for 30 days so they have perspective on what it feels like to not feel that constant inflammatory response internally from what you're putting into your body.
100%.
All of a sudden they're feeling so much better. Then let's say hypothetically they go on a cruise and you got to eat what they, it's not like you can bring 7 days worth of food in with you, and they can't wait to get off the cruise because they were like, oh my gosh, I can't believe I have felt this way for most of my life.
Yeah, it's wild.
You don't realize how much what you're putting in your body is creating your pain.
100%.
So those are the big ones. I think something that we never really talk about, which are just your basics, is making sure you've got a good microbiome and making sure you're sleeping well. Those are two really big ones when we talk about inflammatory responses and the cascade of issues that happen when we're not getting those very basics done. But then I would say if we start talking about, okay, well then how would I eat in a way that is anti-inflammatory? You can Google the anti-inflammatory diet. You can Google the Mediterranean diet, which is known to be anti-inflammatory. You can get those, but what it's going to be is mostly a lot of plants, because those plants are the polyphenols, all of the chemicals, which we call flavonoids and polyphenols and antioxidants that are in the foods are actually getting rid of the oxidative stress or the free radicals that are causing the inflammatory response, which in turn is causing the pain. So the more you have those circulating and on board, the more it's going to scavenge those guys and get rid of them so that they don't cause pain. But good fats like nuts and avocados and olive oil, especially like cold pressed extra virgin olive oil, avocado oils, all of those in lieu of your seed oils, unless it's high oleic. That's the way I would go. But I think too, it's good to also think about this in a way that one thing is, controlling your blood sugar, because every time your blood sugar is uncontrolled, that too is causing a cascade of issues. So what does that mean? It means eating enough protein, eating good fats, making sure that you're getting a ton of fiber so that you're actually filling up at meals. That's lowering your insulin spike and better controlling your blood sugar.
So let's say we got a plate, okay? Let's say we've got a good portion of protein, a good portion of fat. So let's say you got a big old piece of chicken, got some avocado, you got a salad, got a little bit of carbohydrates. The order in which it goes into your system helps that blood sugar spike, correct?
Yeah, I always really encourage protein first. And that is really going to be what helps satiate people the most. You add a good fat on there that extends that process. And then that way, the carbohydrates that you're taking in later in the meal, the vegetables themselves almost create a mesh in our intestines, which help slow down the absorption of the carbohydrates that are in them. But then let's say you're eating some rice or some pasta or a small, portion of carbohydrate, then it lowers the absorption rate of that so that we are better controlling your blood sugar and you give your body time and insulin time to react. But it does lower that curve. I teach this in my protocol. I actually show kind of what your blood sugar does with the various macronutrients.
Okay, cool. And then protein, of course, I don't want to beat a dead horse, but if you have tissue healing that needs to take place, it's the protein that is broken down that helps the cells in the muscle reaggregate so you can actually get stronger connections in the hypertrophy. So make sure minimum 1.4 to 1.6 grams per kilogram of body weight. Are you on board with that?
Yeah, that can be high for some. I think, when we're giving advice like that, I think you have to make sure we say this is general population. You definitely can't have, kidney disease or liver disease or some other issues that you're dealing with. But I would say let's lower that to 1.2 to 1.6.
For the average population?
Just depends on, yes. The
Okay.
0.8, which was what the RDA was, that really was always just meant to be...
To not die.
To not be deficient.
Right.
It definitely does not take into consideration what we should be doing based on... There are factors. There's activity factors. There's injury factors. There's, different things metabolically that can change that number. What I always try to do is tell everybody no less than 30 ounces at a meal.
30 ounces or 30 grams.
30 grams, 30 ounces. Woo!
That's a big meal.
That is a big meal. You couldn't even do that.
Yeah. 30 grams.
Yeah.
And there's some data that shows bigger people like me, I'm over 200 pounds, I can absorb up to 50 grams at a meal. And that's what I actually try to go for every meal.
For every ounce of animal meat, that is 7 grams of protein. So you just multiply however many ounces you're eating times 7, try to shoot for no less than 30.
Yeah.
That's generally. Okay. In addition to that, if I'm giving my list, is hydration. Making sure that you're staying properly hydrated, because if you're dealing with sludge inside, nothing is going to work properly.
Okay, so the reason you say sludge is people hear inflammation, but they technically don't. A lot of people technically don't know what it is. If you look at a blood vessel, or if you look in the intestines, it needs to be really slippery. It's like the inside of your mouth, okay? You want it slippery. The mucosa, which is anything that is inside of your nasal passages, that has to be slippery. When you have inflammation, that gets sticky. Okay, you don't want a sticky artery with blood going through it, because then things stick to the walls, and that's how you get clotting. Okay, same thing with the intestines. You want the intestines to be slippery. You want it to be nice and slick, like a kid going through a slide at a water park. Okay, you don't want a sticky intestine. Okay, so like Shannon's saying, if you got that sludge in there because you're dehydrated, it's no longer slippery and it's going to get stuck, and there's your inflammation.
And, there's your pain. And I mean, everything is just not, if you think about, your body is mostly made up of water. If you are dehydrated and not hydrated properly, nothing's going to function like it's supposed to.
Yeah.
That in turn can cause significant pain.
Okay, so talk real quick, ideal hydration.
Ideal hydration, it's really, again, this is very individualized. I think we could very broadly say, for every kilogram of body weight is an ounce of water. Okay. However, I honestly think that most everybody, depending on what they're dealing with metabolically, should shoot for close to 100 ounces a day.
Okay.
It used to be the 8 ounces a day, which is 64 ounces. And that's great. That's a great start. But honestly, if you are thirsty, you are already in the first stages of dehydration.
Yeah, I had a professor who used to say, if you're thirsty, you're already hypohydrated. You're not dehydrated, you're hypohydrated. And if you're an athlete and you're out on the field, even if you're just a recreational athlete and playing tennis and you're thirsty, you cannot get that back while you're playing. It's already, you have to expect that your output and your function is already going to be low. Because if you're hypohydrated, your blood volume is less, so your heart has to work harder to pump all that blood through.
Again, I think people, when we're talking about anti-inflammatory, I don't think that they would ever think hydration.
Yeah.
But when you think of just the very basics, and this term is largely overused when we talk about low-hanging fruit, but we've got the very basics to life, right? Hydration, we got to sleep. Those are really big ones. Like if we talk about then we can get nitpicky down the road, but I would say let's start with the bigger guys first that make the biggest difference and then move on from there.
Okay.
I think, these particular cups are nice to always have with you at all times, taking constant sips of water. Also, imagine all the sugar that you're getting in the drinks, and that includes these artificial sweeteners that are included in these drinks that are inflammatory and causing issues with our microbiome. So just everybody needs to just get back to drinking and hydrating with water.
Now, where do you stand on electrolytes? Because you and I have gone back and forth on this a little bit. I drink electrolytes every morning when I wake up, because from what I've read You're not consuming anything for 8 or 9 hours if you're sleeping that much, so you're waking up dehydrated. Now, some of the literature I've read is if you're just drinking water, you need some sodium to drive that water into the cell. So if you're drinking a ton of water and you're peeing all day, you may not necessarily be hydrated. So
And I think it depends.
address that.
Yeah, because you don't necessarily eat breakfast. You're still fasting, and that's a different situation than I am, because I am getting sodium and potassium to start my day. So it really just depends. And, you know, a lot of people are not big breakfast eaters, so most likely people would benefit from having the electrolyte drinks to start the day. The other thing that we tend to do is start our day with coffee, which has caffeine, or tea, which has caffeine, which is a diuretic, which makes you pee more. So you can definitely start your day hypohydrated, and the electrolytes can help. Also, if you're sweating a lot, if you're very active, I think they're very beneficial. But I just don't think we can say across the board everybody should be on electrolytes.
Yeah, so maybe as a generic, a little bit of electrolytes in a cup of water before you have your tea or coffee. Drink that down, then drink your tea or coffee. Should be good to go, right?
If they are eating a meal, it's probably not necessary. Depending, I mean, if,
so
if their meal is crap, then maybe.
Yeah, so if you're fasting like me, I typically don't eat my first calories until about 11, 12 o'clock every day.
Right.
So, so if you're waking up and you're having your meal, you're getting sodium, potassium, magnesium from the meal. If you're having a good meal, if you're fasting like me, electrolytes, water, then your tea or coffee. And if you're sweating, you know, I play tennis out here in Florida and I'm drenched. So I actually drink electrolytes while I'm sweating, because, you know, if you sweat in a dark shirt and you see those white lines after it dries, that's salt. I mean, you're losing sodium. So water is not enough. You need some sodium. I think the potassium is not as important from what I understand. Let me double check that. But you need the electrolytes to replenish some of those minerals when you're sweating.
You won't find an electrolyte package that doesn't have potassium in it.
Okay. I remember reading something about potassium,
but I'm just saying they would be, unless you're just putting actually sodium in your water, it's going to be hard to find a package that does not have it. Okay, so really quick, because we need to wrap up here. 3 supplements that I think are very much worth taking for anti-inflammatory is magnesium. It is responsible for over 600 enzymatic processes in your body, and it's definitely a key mineral to us needing for so many bodily functions that it is definitely anti-inflammatory. Omega-3 fish oils, which we both take daily, right? And vitamin D. So that vitamin D should be coupled with a vitamin K as well, because that helps absorption. But vitamin D is also known to be anti-inflammatory.
I didn't know that about vitamin D.
Well, it's not cut and dry. Not everybody absorbs it the same. And so, for instance, I walk outdoors every day. Look at my skin. I get a lot of sun, and my vitamin D levels that I just had tested were barely over the normal level. Okay, so here's the takeaway. Don't assume. Have that level tested and supplement if you need to.
Yeah, it's very cheap. Just make sure it's, again, Transparent Labs has a vitamin D K2 supplement I actually take every morning and every evening. And actually, when I had my labs done about 2 months ago, my vitamin D was high normal, which is right where you want it. And incidentally, when I get sick, which is very, very infrequently, I am over colds like that.
All right, Dr. Rob, we got to wrap up.
All right, we talked a lot, covered some good stuff. But as always, it was fun. I always learn a lot from my wife, and hopefully she learned something from me, and hopefully you all learn from us. I'm Dr. Rob Jones.
I'm Shannon Jones.
I help you get better from the outside in.
And the inside out.
Until next time, get better, not older.